Welcome back to the Better Birth Podcast. I'm super excited to have you on today. We have Michelle Curtis, a LA area labor and delivery nurse. So you've been a nurse for 11 years, right?
Not quite 11. So
Okay.
I transitioned to nursing in 2015.
Okay,
I
cool.
started in 2011 in my undergrad. I actually got my degree in biology first at
Amazing.
Southern Illinois University, and I started at a local hospital in OB. And I just
You
found this
started
really,
it?
really cool job. Yeah. So it was
Wow.
on the job training. The physicians and other surgical techs would train you, and I got to scrub in to every vaginal delivery and C-section with the physicians there. So that kind of what completely changed the trajectory of my life once I did my first couple deliveries and got hooked, because I originally kind of thought I wanted to maybe go into pediatrics, which is very similar. I still, work with babies
hmm
now, but once I had the rush of helping bring life into this world, I was like hooked. I'm, going to switch the whole thing, go to nursing school, and that's what I've done since I was 19 now. So
Yeah.
I tell my patients whenever they need some reassurance or they have a lot of anxiety, I'm like, look, I don't know a lot of things in life. I don't know what it's like to have a normal job, but I've done this since
Yeah.
I was 19. This is where I'm comfortable. This is what I could talk about for days and days, which is also why I, other than believing in your company, agreed to this, because I'm like, this is the one thing in life I can chat about. I typically
Yeah.
am kind of a shy behind the scenes type of person,
Uh,
but
well,
this
yeah. Yeah, I'm super grateful that you're here. And I'd love to intro the episode by just talking about how we met. So we met actually through Facebook
yeah.
Marketplace, which is so unconventional for our guests. But yeah, I was selling my pink gamer chair,
Mhm.
and you bought it. Do you still use it?
Yeah, I still
Okay.
have it. I looked at it. I got ready on it today. So,
That's awesome.
I'm one of those people that I have a scientific background and very, very, believe in studies and stuff, but I have a little bit of superstition in me, as a lot of
Mm-hmm.
medical people actually do, especially in
Mm-hmm.
OB. We have so many things that I could talk about
Yeah, I feel like
that
with
are really,
birth,
really
it's like
fun. Yeah.
astrology.
Yesterday, we were really
Yeah.
busy, and even our supervisors and some of the physicians, we all were like, "Is it a full moon?" And it was. Like, that's one of the first things that we say.
Yeah.
We had a sort of hurricane in Los Angeles lately, and me being from the Midwest, another superstition, this may have some science behind it, we'll have to look it up, is that the barometric pressure, when a storm front is coming
Mhm.
through, can break people's water and send them into labor.
Mm.
And the day of the hurricane, we had so many
The
people.
earthquake.
We had so many people come in with their water broken.
Oh,
So yeah, there's a lot of
wow.
superstitions that we believe in. And I also firmly believe that people are put into your life for a reason, even in the most random things. And sometimes you may not see the signs right away, but I've
Mhm.
always wanted to kind of spread more awareness to certain topics. I've wanted to kind of share my voice and my experience with other people. And so I was new to LA. I decided to decorate my room in all pink. So I had to have the pink gamer
I
chair.
have an
And
all
there's
pink room
quite
too.
a really, I didn't know
Yeah.
that. There was quite a few pink chairs on there. Some were maybe even closer. They were so similar, but I just randomly picked yours and messaged you. And as smart, safe girls do, we both found out later that we creeped on each other on Facebook. And I was like, she has a cord blood company? What in the world? Most people don't even know what cord blood is unless they
Yeah.
have a baby. Let alone I've never met anybody that started one. I know some of the big nationwide one. Who even knows who started those?
Mhm.
So I was kind of nervous on my way over there because I'm like, I need to bring this up to her, but I don't want her to think I'm a weirdo. And I think you were you said it first. You're like, so you work in L&D, and I was like,
Yeah.
you have cord blood, and from there we kind of. Um, Life just happens, and I'm busy with work and I've been here for a couple years now, but making new friends and figuring out my life here. But still, I've always remembered that interaction that we
Mm.
had. It still kind of gets me emotional, and I know your viewers
Aw.
probably know about your brother, but even to this day, probably 4 or 5 days ago, I was just telling her this. I had a dad that was he felt really ill prepared. They came in, they were having the baby a little bit early. And we actually, on admission, this is one of the questions you were going to ask me, he wanted to know about cord blood instead of having it
Mhm.
prepared. And he was really embarrassed. He said, I haven't done any research. And I'm like, no, 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 it's okay. You can do it up until the baby's here. We have kits
Yeah.
here. We can call people. And he's like, what are even the companies? And I mentioned a couple other, and then I actually brought you up, and I'm like, I met somebody a few years ago. She lives in Los Angeles, and You just need to get on her website and, compare all of the companies, but her story always sticks with me.
Aw.
Yeah, yeah.
Thank you. Yeah, no, that was really, really amazing. Cause yeah, I did look before and saw that you were an LND, and we have like our medical director and some of our medical advisors have either been at Cedars or
Mhm.
are at Cedars now. So I feel like just the whole LA like healthcare ecosystem, I just like I'm always really interested when people work in it. My dad's anesthesiologist at Chalk actually.
Oh, I didn't
So
know that.
yeah, so I feel like I've just always had like a little bit of a touch with the LA healthcare work ecosystem.
Yeah, yeah, and it makes sense too with everything that your family's been through and having the
Yeah.
medical background. My mom's a nurse too, so we
Oh,
kind of, like,
cool.
stick with what we know, and that's one thing that I'm finding amazing just from working here, how small this world is.
Mhm.
One of the hospitals that I was at in Los Angeles, a couple of physicians that I kind of say raised me because I started in OB when I was so young and, taught me how to cut suture and different things. They went to school out here, and then some of
Mhm.
the attendings at my job knew them. Like, it's a very tight-knit community, once you start traveling a little bit more.
Yeah. Yeah, that's awesome. Cool. Well, yeah, I'd love to chat a little bit more about cord blood banking in general. I know you brought it up already. But yeah, I would love to get what your take on cord blood banking. Like, what were your initial moments of exposure to cord blood banking? And yeah, how would you think about it for your kids?
I feel like, my initial exposure was actually when I was really, really young too and had no idea what it was at first. And I've got to see both spectrums of things, which I was thinking about this before I came, how I want to describe this because I think it's amazing. I think it's it can be life-saving. I think it's gonna
Mhm.
change the world with some of the studies that are done. And I've been able to see both spectrums of starting in a rural hospital in the middle of America where, most of our patients were predominantly low income. A lot of our providers were involved with the public banking because
Mhm.
unfortunately, as many things in the United States, it's kind of a luxury, at least in my opinion. It's a very
Right.
important one, but some people, especially where I'm originally from, it comes down to buying diapers for your baby or being able to bank cord blood. So I thought it was so amazing that our doctors were like, we know that a lot of our patient population will not be able to afford this, but at least we can make a difference. And
Mhm.
they feel like they are too. Instead of just throwing this placenta away, throwing this cord blood away, we can donate it. To help the future of our country, of our world. And then when I moved we had a couple of patients there that maybe had better jobs, worked at the university that would do private banking. It was pretty rare. And then when I started at Cedars in the middle of Los Angeles, among many other things, I got to see that even for myself personally, um, what a luxury healthcare can be because almost
Yeah.
all of my patients knew about cord blood
Mhm.
and were paying for private banking, which is amazing. I would, if I could. I'm lucky, I have access to good insurance. I have access to healthcare.
Mhm.
Living here now, I'm even realizing I can just go to a specialist if I need something. In Southern Illinois and other rural areas, even with my own family, they have a really, really hard time getting in to see a specialist, and sometimes they have to
Mm.
drive up to 2 hours. So, among many other things, living here has opened my eyes, even as a patient, to some of the luxuries, but
Yeah.
how important they are.
Yeah, for sure. No, even when I go to doctors in LA, like even the office experience is totally different. Like they'll offer me like a poppy, like the drink with
Yeah.
probiotics or
Yeah.
whatever.
Yeah.
It's so different. Okay, cool. Well, yeah, I'm curious how often now parents ask you about cord blood banking. I know you mentioned that one dad asked you, but as
Mhm.
a labor and delivery nurse, how often do parents bring up cord blood banking with you, and what do you say?
It's kind of a similar answer to before. I didn't really get to touch on that, but, like, in the rural areas, their
Hmm.
physicians would maybe bring it up to them, but they didn't have a lot of access to the educational material, so they just were like, "Yeah, we can donate it." A lot of people didn't even know. In
Yeah.
Los Angeles, it seems like people are a little bit more, educated on the topic, so most of my patients know of it and they've had the discussion as a
Hmm.
couple
By the
or
time they get to birth.
yeah, by the time they get to birth, and they either have a hard yes or a hard no. It's pretty rare that I actually have to explain and bring up different companies like I did the other day. Most people come
Yeah.
in with a plan.
Okay, interesting.
Mhm.
Cool. So, yeah, what do you say when parents ask your opinion on cord blood banking?
I tell them it if they ask me the same question if I would do it, I give them an honest answer.
Mhm.
I try in my practice in general to just give people factual information and
Yeah.
kind of let them I don't wanna sway them one way or another. That's something that's really, really, important to me. So I'll, like, explain to them, what it is, and
Mhm.
one of the sayings that I've heard a lot from growing up in OB and what I still say is it's like an insurance policy,
Mhm.
among other things. If you're gonna private bank it, you have it there if you need it. Hopefully, you never have to use it. I think I told you this actually whenever we met. Up until I met you, I would also tell people the truth that I've never known anybody that has had to use it, thank
Mm.
God.
Yeah.
But it's there. But then now I cannot say that anymore, and it's okay. I'm like, I met somebody that
Yeah.
really needed it,
Right.
and they didn't have access at that time, and, because of that, she is trying to change the world and starting her own company, like, in honor of her brother, so
Yeah, no, it's kind of interesting. Like even earlier, I was telling you we had lunch with an OB, and I was telling her about my brother being in a near drowning accident and getting cerebral palsy, and she actually said that she had a patient that had a really similar experience. Her third child had a near drowning accident, and similarly was airlifted, and like same with my brother from like a lake, and then was diagnosed with cerebral palsy. So they were looking into cord blood stem cells, and they had banked for their first baby, but they didn't for the second and third because they just kind of didn't think it was that necessary. But then similarly, like was suddenly wishing that they had more access to stem cells. So yeah, I think it's more common than people even think, just because I feel like so few parents, or even the ones that bank, I think their exposure to use cases is so limited after they bank, and they just kind of stop thinking about it. So yeah, the reason I love doing this podcast is so we can keep people up to date with like research, and even keep like providers up to date, and just let them know about what's happening with cord blood stem cells.
mhm. Yeah, that's like another right, whenever you were speaking, another thing that I thought of, that I might even have been guilty of until, once again, I met you, is that you would assume, a lot of people just assume birth injury, right? So
Hmm.
they're thinking, I know, like, there's certain things you have to do to pay to keep the blood stored, and, whenever their kid reaches school age or whatever, they're like, "Okay, everything's fine," and they may not
Yeah.
continue to pay for the storage fee. But unfortunately, like, this is a tough world and accidents happen no matter
Right.
how old your kid is, even when they're grown, so that's probably something, maybe a decision I could see that people are struggling with, especially if money's tight. Once the kids are at school and they're like, "Okay, everything's good. They seem to be learning well. All of their checkups have been good. Let's just not,
Yeah.
continue to pay for this, and we can use that money for something else." But, I mean, both of those stories are proof of how important it can be to have something as
Yeah,
an
for
insurance
sure.
policy.
Yeah. I'm curious if you've ever had exposure to sort of the research side of stem cell related work, even just in your education.
Yeah, yeah,
Like, how would
if
you
if I
explain
were
stem cell
if I were to
science?
say in nursing school, if I have to look back on it, we didn't have a lot, but because I have the, degree in biology too,
Mm.
with, like, micro classes
Oh,
and
yeah.
everything, I, had a little bit more how I would explain it just to patients probably, um I would explain to them that stem cells still it's still like a new science, really, if you think about it. I think in my lifetime
Yeah.
we've heard more about it, but they're able to, just in the last few years even, potentially grow organs, like, one day, potentially, you know about probably CRISPR too, like,
Mhm.
they're finding out that they're able to manipulate genes if they need to, like, cut into
Mhm.
DNA, but more importantly, they can be used just for something as simple as, like, a bone marrow transplant
Mhm.
if your child gets leukemia down the line, which we'll have to fact check me on this, but I think childhood like, leukemia is one of the most common types of
Yeah.
I'm not, in pediatrics to just deal with neonatal stuff, but I believe leukemia is one of the most common, um, types of childhood cancer. So for bone marrow transplants, it can be used like
Mhm.
the opportunities are endless.
Yeah.
And even if you another actually question I had for you that I was
Yeah.
really, really curious about, are there options for parents to so obviously you know how much we collect in the kit.
Mhm.
Is there an option to do like a half and half, bank half of it or maybe collect more and then donate the rest to science? Because the part that I would have a problem with, I think personally, because I knew that was gonna be one of our questions, is I would want research to be being done
Mm.
too. I don't just want
Yeah.
all of my baby's cord blood to be sitting in,
Mhm.
on ice essentially and
Yeah.
not get used. So are there options to do?
Yeah, yeah, for sure. Yeah. So we actually just brokered a partnership with a company that does research. So sometimes what happens is parents will sign up to collect with us, but then like they won't collect enough cord tissue or there won't be enough cord blood because they didn't milk the cord or whatever. So
Mhm.
in those cases, we'll usually reach out to parents and ask them like, "Are you okay with us discarding this?" But because we of this new partnership, we just instituted it last Friday, but because of this now, when we reach out and ask, do you want us to discard this? Instead, we'll also say, like, would you instead like to donate this to research? So it's either donated to research or donated to be the match, so that it can be donated to someone that's on a donor list. Um, and so, yeah, so there is a way for them to do that even through us.
Mhm.
So people can choose to bank, for instance, just cord blood and then donate their cord tissue or their placenta. So they can donate like one of them. And yeah, or even two of them. So yeah, there are definitely ways around it.
Mhm. That's amazing. That's amazing. I think there's a huge opportunity, for a lot of essentially right now what is medical waste, and
Yeah.
I think there's commonly kind of a distrust for the medical system. I've heard a question I get almost daily, not daily, let's say weekly, is, "Are you selling babies'
Yeah.
foreskin for
Oh,
circumcisions?" Which I'm
force.
not laughing at that question, but I mean, it is
Yeah.
bizarre to me, and I can actually tell my, patients that I've pretty much just like, by that point in the day, developed a really trusting, like, rapport with that.
Hmm.
I'm like, I personally have experience, in the hospital. Sometimes I would have to assist with circumcisions,
Mm.
which is kind of an elective procedure, but I was the one who would physically, like, throw it away. It's like
Yeah.
too much for this podcast.
No,
But,
no.
like, we would just throw it in a bag with medical waste, and I'm like, I assure you nobody was digging through sorry, I said that,
Yeah.
like, with the blood and needles and whatever, and then it's the same thing with placentas too. I actually have a
Hmm.
really unique experience with that as a obstetrician, like, technician early on before nursing school. One of our tasky things that we all hated was we had to throw away the placentas. We would keep them for about a week in the
Hmm.
fridge, on everybody that delivered if they chose not to keep it or bank it, which that's a newer thing too
Yeah.
for banking the placentas. I've had a lot of people encapsulate them, but
Hmm.
the actually donating them or not donating them, storing them with companies is kind of a newer thing that I'm hearing about. But I was essentially the person, me and my other coworkers, who had to throw them away after they'd been in there for about a week, and we would save them just in case patients changed their mind. So
Yeah.
it's a lot of waste, and I
Yeah.
think a lot of research could be being done on these things.
Hmm.
So
Yeah.
it's another thing that I think I'm happy that it's kind of starting to change.
Yeah, yeah, it's interesting because a lot of, like, doulas, midwives, and OBs, like, they've pretty much every type of birth provider has mentioned to me that we know very little about the placenta,
Mhm.
which is so crazy because I feel like it's so essential, and I feel like even a lot of young men don't even know what a placenta is until maybe they're a dad.
Mhm. Mhm.
So, yeah, I think it's kind of interesting, like, even me going to, like, networking events or whatever, if I meet young other entrepreneurs, they'll be like, "What do you do?" And I mention, and they're kind of like, "What even is a placenta?"
Yeah, yeah.
Yeah.
We love placentas. If people can get over the initial gore, if they're not really queasy
Yeah.
with blood, I always ask mom and dad if they wanna see her placenta before I,
Mm.
usually discard it, if they're
Yeah.
not doing anything with it, because I tell them if they're interested and kind of show them both sides. And like, this is probably your only organ you're going to see in your life. And
Yeah.
not only that, you grew this organ so fast. Like, it's humongous, but you grew this
Yeah.
in 40 weeks, maybe a little bit earlier, like, to be fully developed. And your body knew, is so smart that it knew to just, okay, let's be done with it after. That doesn't happen.
Yeah.
Sometimes we have some problems after delivery. And then I tell them just how amazing it's literally the miracle of life. One little thing goes wrong with that placenta. We know some things,
Mhm.
and it could be catastrophic.
Right.
So I always encourage patients to look at it if they can stand that kind of stuff, because it's really cool to me that that's the only time you're probably going to see your organ,
Yeah.
unless you get, like, an appendectomy and ask your surgeon.
Right.
You're like, I'm a weirdo. Can I see it? Which I would, but
Yeah. Yeah. Okay, that's awesome. So yeah, no, we actually get a lot of comments around like, do you sell? Or it's not if we sell, but typically if I say like you should bank your placenta instead of throw it away, I'll get a
Mhm.
lot of comments along the lines of like, OMG, they don't throw it away, they sell them.
I know.
So yeah, so what happens after they go in the medical waste bin? Is it incinerated
Yeah,
or
yeah,
okay?
it literally gets mixed in with all of the medical waste, and
Mhm.
I assure you guys these are not usable after that because at least at most of the hospitals I've been at, it's, depending on how busy they are, the biohazard waste is like, at least every other day. It's not like an every hour pickup, so they're essentially getting taken out of the fridge or whatever when we're not using them anymore, which,
Mm.
by the way, some hospitals don't even keep them in the fridge, they just throw them immediately away, but they're, not, like, in the refrigerator anymore in some cases, and they're kind of just sitting out decaying all day until they
Mm.
get the medical waste out, so
Oh, wow.
I nobody wants those.
Yeah.
However, I'm now, thinking because of, like, doing this and I've heard a
Mhm.
couple other people recently donating theirs, I'm like, "Wow, we should be doing that,"
Yeah,
because we are missing an opportunity for research at least.
for sure.
Another thing that I didn't mention is there are certain situations, and it depends on the obstetrician, if we have any concerns with the baby after delivery or how the labor did, we're gonna want to know more later on. Maybe the baby gets admitted to the NICU,
Mm.
for kind of an unknown reason. At the moment, the baby needed some extra resuscitation after delivery, or mom has some kind of complication going on, we will, in certain cases, send the placentas to pathology.
Mhm.
Some people watching this may have had theirs before, and from there, a pathologist really looks through it under a microscope with a fine tooth comb, does different tests on it, and it can usually kind of tell us the story of what happened.
Right. Okay, awesome. Yeah, we get quite a few people that wanna bank with us that then their placenta gets sent to pathology, so we
Hmm.
kind of have to take it back.
Yeah, yeah.
Cool. Well, I know one thing that we were chatting about earlier was the nursing shortage that's happening right now. So I want to chat about an article published by nurses.org. It basically stated that between 2020 to 2023, demand has, or basically supply of nurses has decreased by 4% in order to meet national demand. And also with that, during the pandemic, a lot of maternal health care deserts were increasing. So yeah, I wanted to get your personal take on just what's happening right now with nurses. How is the nursing shortage impacting you? How do you see it impacting your work?
Yeah, so I remember actually learning about this in nursing school. One of our professors introduced the idea of the nursing shortage, and I think it's something that like a lot of us have always heard about. I would say when I first started as a nurse in healthcare, I felt it a little bit, but not as bad as post pandemic. Even during the pandemic, we felt it a little bit. A lot of people were getting sick, a lot of people were quitting, but there's this trend where afterwards, a lot of people are going into like health tech now.
Hmm.
They're completely switching careers. The burnout to me just feels so much higher, and it terrifies me. A lot of
Mm.
times, especially in labor and delivery, I I try to be honest with my patients. Something that I learned early on, and I really can't remember if it was on the job or in nursing school, is that they kind of want us to, and you'll still hear this every once in a while at different hospitals. They want us to kind of just pretend everything's okay. Don't you dare mention to your patients that we're dangerously staffed today, that you have
Mm.
many more patients than you're supposed to. Don't mention to your patients that it's 5 p.m., you're 10 hours into your shift and you haven't had a drink of
Mm.
water and nobody's going to get lunch on the floor. It's kind of this, I think, toxic environment. And since I actually started travel nursing, I feel a little bit more like I'm my own boss, and I'm just like a brutally honest person. So I'll tell my patients the truth because I think we're all human. And if I can look at them and say, I'm dealing with an emergency in the other room right now. Everybody in the hospital or everybody on the floor is dealing with this like life or death emergency. But I want you to know I'm still watching your baby, and I'll be here if you need me. But like, I just want to explain to you why I was so, sorry, I was so
Like
like,
frazzled.
yeah, or like, earlier in the day, like, before this emergency happened or people left, I was able to give you a lot more attention, and now it kinda seems like,
Mm.
"Oh, where's Michelle going? Why is she disappearing?" And it's just
Hmm.
because we're feeling the shortage, and it's dangerous.
Yeah.
Um, a lot of times recently we used to go, most hospitals in L&D would go by ACOG or A1
Mhm.
standards. So for that, we'll have to like pull them up. But it basically states that for a high risk laboring patient, the nurse actually should be one-on-one. If they have
Mm.
an epidural, if they are on Pitocin, which is very, very common, and there's a bunch
Mhm.
of other things that we can look at later, they should just have one, like that should be your only patient. And to me, I've always explained that to people because we're, as far as I know, the only field where 1 second I'm standing in the room with you and the next second your baby's heart rate goes down, and we
Mm.
do everything we can to get it back up, but baby's heart rate isn't coming back up, and we're in the OR within like 2 minutes. And guess who is the operating room nurse all of a sudden? Your L&D nurse. There's not a lot
Mhm.
of like floor nurses that immediately convert to an operating room nurse. And if I
Yeah.
have another patient, I'm essentially abandoning her and hoping my charge nurse takes care of her while I'm in the operating room for, however many hours.
Mhm.
So we used to follow those. It felt like more whenever I started in OB, and that's kind of out the window lately. I've had a lot of charge nurses say that
Mhm.
like those old safe staffing ratios are just out the window.
Hmm.
And it's really scary and frustrating for all of us.
Hmm. So if someone is currently even a little bit interested in nursing, what would you say to them?
That's so hard because I'm still here.
Yeah.
I especially in labor and delivery, I think I can do other things with my life, but I always want to stay at least part-time bedside because it is one of the most amazing jobs that you can ever imagine. I tell newer nurses that I'm training that you may not realize this at the time, but even it's just a normal day for you. You do a couple deliveries every day, but these people are going to remember you for the rest of their lives.
Mm.
I've talked to, my mom's friends or whoever, and they're 50 or 60, and they're like, "Oh, I still remember my labor and delivery nurse, Catherine, and she was so
Yeah.
nice," because it's such a important day in their life, and that's why moms and dads and whoever do so much prep work for this
Yeah.
delivery because they know how important it's gonna be. And whenever you're there and you kind of become really close with these people over 12 hours because you're their
Mhm.
only nurse, and it's different from the other fields in healthcare because if somebody's like on Pitocin, for instance, I'm in their room like every 15 minutes. I pretty much am just in there for 12 hours. So they learn everything about me. I learn everything about them. And you all are really going through these challenges together because every labor is different.
Right.
Every birth is different. So you're all working together as a team. And whenever she finally delivers, I'm always tell every single mom that I have that I'm so proud of them because
Mm.
it's just cool. It's so cool to see
Yeah,
them
that's so
like
sweet.
yeah, yeah, and so that it's worth it, but then there's the double-edged sword of, like, I care about these people so much and I bonded with them, I wanna keep them safe.
Yeah.
But if there's nobody to take care of them, like, what do we do?
Mm.
You can't say no to all of these assignments because then there's a mom in the hallway with no nurse.
Mhm.
But also if I take on another patient, I know that it's against every rule that's ever been written. It's really stressful, and it's something that I never thought I would have to deal with to this extent.
Right. Yeah, I was mentioning that my dad's an anesthesiologist, and he told me that he
He knows too.
recently read a study that, oh, your dad's an anesthesiologist? Oh, okay.
No, no, sorry, you said that, yeah.
Yeah, yeah, and he was saying that he read a study, I think Stanford Medical School, now 25% of their graduates are just going immediately into tech and never practicing.
Mhm,
And he was saying, like, in general, he's finding that most people that intend to go in the medical field end up bowing out to do something else
mhm,
at some point. Like, even one of our medical advisors practiced for over 10 years as an OB and now is working in health tech as head of business development. So, yeah, it's kind of interesting this just sort of like dynamic happening in the US healthcare system.
mhm. And if you talk to most people, they will say, burnout's the number one reason, but it's not that they've changed, their mind. We still love people, we love helping people, but it just gets to a point where we feel like we can't be a part of this anymore, and I don't have the answers. I've thought about it, maybe one day I will. I really think something I firmly believe is that more nurses and physicians should be the people making these decisions in
Yeah.
hospitals, not people that went to school for, um, a business degree in hospital administration. And
Mhm.
they really, really need nurses, especially on these boards, because we we're so like we're an important part of the puzzle. Every team is, but the people that are actually running the day-to-day operations of hospitals are nurses. Especially, I can only speak on OB once again because it's all I've ever done, but our physicians have their own thing that they're doing. They're very busy seeing patients all day in the office, and I'm calling them with anything that's going wrong. And whenever they're on the floor, they may have 4 other women in labor, and they may be
Yeah.
pushing with, a patient. So your L&D nurse, is there with you probably, if I had to guess, like 95% of the time doing everything with
Mhm.
you. And we even usually start pushing with them too. Like that's within our scope. And we'll call the physician whenever the baby's like about to come. I've
Mhm.
have a lot of patients joke about that I've had babies before where they're like, "Last time my doctor didn't show up until 5 minutes." And I'm like, "That'll probably happen again." And I'm
Yeah.
like, "But it's because, remember when you saw them in the or in the office all of those times? If they were pushing with everybody for 2 to 3
Mm.
hours, they wouldn't be able to ever see you." So we have like we work together, but we're doing so much of the day-to-day operations. We're drawing blood. We really have our feet on the floor and we know how hospitals work. So it's
Yeah.
always puzzled me that on these boards making these decisions and cuts and whatever, why aren't people who have a lot of experience on the floor helping make these decisions?
Right. Right. Um, yeah, I feel like there's so many birth workers that most people don't even traditionally view in the ecosystem. Like even me doing this company and this podcast, like now we've had like a midwife doula, OB, even within OBs, like we've had like a maternal fetal medicine
Mhm.
specialist. And then like next week we're having like a non-high risk OB, but
Mhm.
like they still do high risk, and then like L&D nurse, and there's like NICU nurses. So I feel like there's so many different pieces to the ecosystem that most people don't even like know about.
Yeah, yeah, or even, like, me being a tech for so long. I did
Yeah.
more deliveries actually as a tech,
Interesting.
before I was a nurse because you have to go to usually everyone on the floor, every
Yeah.
delivery and C-section, so that means you're in there for all of those emergencies too.
Mhm.
Anything that can go wrong, I was there. If you're just a labor nurse, you have your one not just, but, you have your 1 or 2 laboring patients. I was
Yeah.
seeing, like, sometimes 15 deliveries a day
Oh,
or, like,
wow.
my hands in there helping.
Yeah.
So I was exposed to so many things and really, like, an important part of that team too.
Yeah. That's so
And
awesome.
I have to give a shout out to my techs because 'cause they're very, very important, and I'm so grateful for them.
Yeah, that's so cool. Okay, cool. Well, since you've been to so many births, I wanted to pick your brain on some FAQs that we frequently get on social media just about labor and delivery in
Mhm.
general. So the first one that I think a lot of, especially first time moms, wonder about is how should parents prepare for labor and delivery? Like if they're in their 7th month of pregnancy as a labor and delivery nurse, what steps would you recommend to prepare for birth?
That's a really, really good one. I think one of the more important things is to really discuss together, how you want your birth to go, like, with your significant other, whoever's there to support you. They're so, so important in labor. And then you need to be thinking about pain management too. This can always change at the
Mm,
last minute, but I tell a lot of people that are really, really set on wanting to do a natural delivery with no pain medicine, that requires a lot of prep work,
hmm.
to be successful, especially for your first baby, because they typically take a lot longer.
Yeah.
So you need to kind of be and your nurse will help you, if she can. This is another thing, like, I love to be in there helping, and giving my expertise, but sometimes if I have another patient, pushing too, I
Mm,
can't be in there to show all the tricks,
yeah.
that I've learned that kind of help optimally position baby, or if you're having back labor, different I have, like, a comb trick too that I learned from a doula, which is my next point is that, a good doula is amazing,
Mm,
absolutely amazing. If you feel like maybe your support person isn't great with seeing you in pain or blood or, anything, if you have any kind of not caveat, hesitation there, maybe look in and get some suggestions, to a doula because they're really,
mm,
really gonna help with that. It's I've never been through it, but I think it's very, very mentally challenging to be able to have, especially with your first a natural labor. So that requires a lot of prep work. You need to be thinking about pediatrician for baby. So
mm,
typically, and this is pretty much anywhere, a lot of you can have a pediatrician that doesn't go to the hospital that you're delivering at because you're going to take your baby to like an outpatient clinic anyway outside of the hospital. So you need to kind of be thinking about pediatrician and then also be aware of if the pediatrician that you guys decide doesn't come to the hospital, we'll just have one of our pediatricians see them while you're
mhm.
still in the hospital, and then they'll essentially pass off care to and the records to your pediatrician that you've chosen for like outside of the hospital. My most common one that I tell people, but they don't usually listen, and I honestly think I would be the same way. The second and third and fourth time parents watching this will laugh and completely agree. I tell people they don't need to bring much to the hospital.
Mm.
It actually adds so much extra stress onto the dad, especially. I'm sorry, I keep saying dad, support person.
Yeah.
Um, because you don't even open those bags. Everybody tells me that at the end of their labor that, "Oh my gosh, I didn't open these." So we have everything you could possibly imagine at the
Mm.
hospitals, and you're kind of paying for it if you think about it.
Yeah.
We give you diapers, we give you wipes, we give you, you may wanna wear your own gown. I tell people that because I kind of like comfortable material too, but just
Mhm.
know it's gonna get gross. So bring a
Mm.
couple, and we can't avoid that. And make sure if you, do wanna have, like, epidural anesthesia, you get one of those. There's some amazing ones now online, that, like, open in the back where the anesthesiologist can,
Mm.
your dad will say this too, can easily access the back. And then for breastfeeding too, you wanna be able to easily, like, unbutton. So that one I would bring, and your own pillow. Our pillows are
Mhm.
horrible at the hospital. They have their own, like, purpose too, but, they're good. And literally other than gown and pillow, and then if you're, like, a little high maintenance like me and you like your own shampoos and face wash and
Mm.
stuff, but all of the other stuff you do not need. You don't need breastfeeding, or, like, pumping kits. We have all of that unless you have a really specific type of, pump.
Mm.
You don't need really anything except a gown and a pillow. And if you're breastfeeding, the baby and you are both gonna be naked for most of the time, so really don't even worry
Yeah.
about bringing baby clothes until you're going home outfit for the baby, bring that, but other than that, we have everything you could possibly imagine.
Okay, cool. I would just add to that a cord blood banking kit if you're looking.
Yes, yes, absolutely. Thank you. That is a good one. You need to discuss that ahead of time, but then as we learned, like, even if you didn't, don't panic because
Yeah.
your nurses are educated in this. And, we can usually labor is usually a long time
Yeah.
for at least the first. If it's your second or third, you should kind of have a plan, but usually
Mhm.
we have a lot of downtime. So the other day, the story I was telling you about, it was early. It was a mm, couple weeks early at least, maybe 4 or 5 weeks early,
Right.
and they were panicking because this was the next discussion they were gonna have, and I'm like, "It's okay. We still have plenty of time. We probably have about 12 more hours." And I gave the dad the job of looking up the different companies now, and I knew that we could probably get somebody there,
Yeah.
with the kit within. Actually have a question for that, and I
Yeah.
don't know if you'll wanna keep this in. Say it's a smaller, new company,
Mhm.
because a lot of hospitals just have kits on hand.
Yeah.
Is it possible to store it in something until we can get the actual kit in for, like, a last minute
Yeah.
delivery like that?
Yeah, for sure. Yeah, I mean, especially because cord blood, I mean, you do need a cord blood bag. So that's important. But yeah, even like you said, some hospitals just already have cord blood
Uh-huh.
bags. But the cord tissue and placenta itself is basically just kept in a jar
Mhm.
in our kit, and that can be kept at room temperature for up to 72 hours. So
Mhm.
if anything, like if even if they don't have a cord blood bag, if parents give birth and they last minute want to bank something
Mhm.
from that has stem cells in it for future disease treatment, then yeah, they can bank the cord tissue and placenta at the very least. But even so, like we've had parents buy our kits like the day that they're giving birth. So
Yeah, yeah.
and we've still been able to get it to them. Like I think the latest we've done is someone ordered a kit when they were 4 centimeters dilated. So we have a bunch of emergency kits essentially in like different units around the country.
That's
So
what was my next
yeah.
suggestion because a lot of places,
Yeah.
we just have them laying around. That's what I told him. I was like,
Right.
"Oh," I'm like, "Let me go look in the back. I know I saw, like, this company and this company," and,
Yeah. No, for
um,
sure.
I didn't know, and I don't know how the other companies will feel either, but, like, if we had to in a pinch, they chose a different company, but we have this bag
Right.
and whatever because it's all, like, for the greater good and, a good cause, so it's
Yeah.
a good
Yeah,
suggestion.
definitely. Yeah. So we'll send a parent a kit. Like pretty much we'll like go to the ends of the earth to try and get it to them.
Mhm.
So yeah, it just depends. But yeah, so another question I had was, is there a warning sign that your water is about to break if you're pregnant?
None, because I
Okay.
I get shocked by it to this day sometimes too. It's
Okay.
it's pretty rare, at least in my experience, for, your water to break on its own during labor. Now, actually, there's a caveat to this, that your labor and delivery nurse or your obstetrician while you're in labor, we might have some kind of inkling by checking your cervix, but other, like, times, somebody will be in labor, and I'll have them on the monitor, and it's actually, like I said, only happened a couple of times where you hear a pop, and it scares all of
Oh,
us because
wow.
the external monitor amplifies everything. That's how we can
Oh,
hear the baby,
right.
So when it happens when somebody's in labor naturally, it's like on the
Oh,
monitor.
so
It's
it's
hard to
literally like a
explain, and I'm always
balloon.
like, "Did your water just break?" And they're like, "Yeah," and I usually get excited too, even though, like, everyone's water breaks every day that
Yeah.
I work, we're usually doing it. The caveat that I was gonna say is that if we check your cervix, there's something called a bulgy bag or bulging bag, depending on where you're at in the country. My southern people where I'm from, bulgy bag. Um, but it's essentially for the person checking you will feel the cervix, and then it feels like I tell new nurses there's a water balloon popping out,
Mhm.
and that gives us some inkling that it may break soon because it's already,
Mm.
kind of popping through. But even then, I've had people have a bulging bag for hours sometimes, and we still have to end up popping it.
Oh,
Some people
wow.
even deliver, it's really rare, but in call where the baby's still in the sac.
Mm.
So no, unfortunately, no real warning sign for your water breaking or even honestly for labor. I hate to say that, but it's another thing that goes back into like more research because we
Yeah.
don't really know if somebody's even going to go into preterm labor. We have a couple tests that we can do in
Mhm.
the hospital, but a lot of times they're inconclusive and not
Mm.
super reliable. So, what I tell people is, like, if we knew, we'd be able to have, like, a cure. Same thing with preeclampsia, like, we have certain statistics that tell us, you may be at higher risk for preeclampsia, but if we knew exactly what caused it or, when it was gonna happen, we could prevent it.
Yeah. Okay, interesting. Yeah, when Dr. Steve Rad was on the
Mhm.
podcast, he told a story about one of his patients' amniotic sacs basically like sticking out. And they were only 23 weeks, I think. So he essentially had to sew their cervix
A
closed.
cerclage,
Yeah,
yes.
yeah. And so that was a crazy story. And he was saying too, I asked him around about the most common causes of like stillbirth and miscarriage and things like that. And he was like, honestly, the most common cause is completely unknown. Like, I feel like in general around pregnancy and birth, there's just such little that's factually known.
Mhm. Yeah, that's another one of my, like, that I'll never be quiet about and life's causes is that for whatever reason women's health is just like, "Oh, we don't know." We put
Yeah.
all of this funding, government and that's another thing that I, like, encourage people to do is talk to, like and also pay attention to who you're electing and just have it be known that women's health is so important. They're
Yeah.
51% of the population, um, and for half of the population, over half, we're kinda just like, "We don't know about a couple of things." Like, preeclampsia is something that in theory we should be able to prevent by now, and as
Mm,
far as I know, the current practice is just, "Oh, you might be at high risk, just pop a baby aspirin and we'll see if
mm,
it helps."
yeah.
And then, yeah, the same thing with birth too. We should be able with the technological advancements and as far as some things have come, we should be able to at least have answers for some of this stuff, and right now it's just,
Right.
you know, but some things have changed. One of my favorite stories to tell people is, so the current treatment for preeclampsia is delivery, but also giving magnesium, which can be
Mm,
a life-saving drug. It's not fun. If you ask anybody that's had it, they'll immediately be like, "Oh, it's not fun." It can make you really, really hot, really drowsy,
mm,
really everyone has kind of a different experience with it. But it essentially keeps mom from seizing because when you're preeclamptic, your blood pressures are really, really high. You're in this like hypertonic state, as we call it.
mm.
So we have to give them magnesium, to
So just
prevent
a really high
seizure,
dose.
stroke. They actually have to stay on it. The
Oh, okay.
current standard, I believe, is they have to stay on it till they deliver
Mm,
for preeclampsia and then for 24 hours after they deliver too. So it's a pretty long time. Nobody ever loves it,
mhm.
but it's keeping, them alive. Uh, within the last, I wanna say 30 years because a lot of, more experienced nurses that have trained me, love to tell the story of whenever they were younger nurses, the antepartum units with preeclamptic moms, the current treatment was actual alcohol drips. So
Mm.
instead of, because
Wow.
they didn't know like magnesium would work the same then. So you would
Yeah.
walk up and down any antepartum unit in the country, these nurses would say, and you could hear people giggling and like having hiccups because they were essentially drunk on like a pure alcohol drip, because that kind of, I guess, did the same thing to
Yeah.
get them out of that hypertonic state, which makes sense. You know, it's a
Mm.
central nervous system depressant. So they were
Right,
kind of just
right.
enjoying it, which, yeah, so just in the last however many years, with
Yeah.
people that are still working in the medical field, it's changed from alcohol to magnesium. So
Oh,
some
wow.
advancements are being made, but
That's
we don't
funny.
have drunk pregnant women anymore on the antepartum
Well,
units.
I talked to a mom that gave birth about a year ago this past weekend, and she told me that as soon as her water broke, she was drinking wine, and she drank wine on the way to birth because she felt really nauseous and sick. So is it okay to drink after your water breaks?
I have never had anybody ask me that. I would say probably not, because until you deliver
Mhm.
your placenta, um, stuff is still, or until we cut the cord,
Right.
stuff is still passing to baby. So I
Mhm.
don't really know the exact, like, percentages, but anything we give you, we have to think about, right? And I'm pretty sure,
Right.
yeah, I know alcohol crosses the placental barrier, which is,
Mhm.
um, so yeah, I wouldn't recommend that. They need to talk to their doctor about it.
Okay, noted.
Yeah, yeah. And then also, like, no judgment if you read that online, just make sure, once again, not recommending it at all, but just make sure you tell your team, honestly, anything that you've ingested. That's like a really, really important thing that
Yeah.
I like to tell people. I assure you, we're not going to judge you, but we're,
Mhm.
going to be giving you different medications, or if you end up in surgery, we need to know kind of what we're working with. The whole team does. The anesthesiologist needs to know, just because even some supplements can interact with certain
Mhm.
drugs that we give. So we really, really need to know everything.
Right, that makes sense. Okay, cool. Well, on the subject of your water breaking, another common question from pregnant parents is what is the difference between losing your mucus plug and your water breaking? And I think a lot of pregnant parents honestly don't even know what a mucus plug is if you want to start there.
Um, Honestly, in obstetrician, I really didn't. I don't have like as much knowledge on the mucus plug as like what it's actually. No, I do. I have to just bring it back up.
I think it's like a cervical
Yeah,
plug,
yeah. So
basically.
you can lose it. At least what I've always like heard doctors say whenever the first thing is we're not concerned about it at all, and we honestly we don't care because it doesn't do anything. Like the mucus
Yeah.
plug, it doesn't indicate that labor is going to start anytime soon.
Mm.
And some people, I've had them lose it really, really early, and they'll come into the unit. Some people even bring it. You don't need to bring it at all. We don't need. It's okay. We believe you, but it really doesn't like indicate labor is starting. I think it's
Mm.
just like a little bit of an extra barrier, right? If I remember, I
Yeah.
think for bacteria.
And it just looks like discharge,
Yeah,
right?
yeah. So that really means nothing for us. When your water breaks, it can be tricky too, because
Mhm.
there's two different kind of types of leaks, I like to say. So there's the in the movies leak where you're in, Ralph's and boom, water balloon, like it's your pants are soaked, it's a whole scene. But then there's
Yeah.
also what we call, some people call it, depending on where you're at in the country, like a high leak or a slow leak,
Mm.
where you're just little by little dripping a little bit out. It hasn't fully busted. And sometimes, by the way, those can heal. I don't know if Dr. Rad told you about that, but
Mm.
sometimes when a mom is really, really early and her water breaks, we we keep her on an antepartum unit, we keep her on bed rest, we do all kinds of things. And sometimes if it's one of those high leaks, it can actually kind of heal itself, and she'll stop leaking, and
Mm.
slowly her amniotic fluid, her AFI is what we call it, will build back up. And we're like, cool, awesome. She's still
Oh,
high
okay.
risk, but there
Yeah.
are cases of that, not always. Um, but my point with that is, if it's like on the movies, yes, come in. You probably are. We call that grossly ruptured.
Mm.
That's another thing I'd love to get out to the whole world, because that's just a medical term that we use. It means like very, very, your water's very broke. But I've had a couple patients throughout the years that I felt so bad, and I'm glad that they at least asked about it.
Mhm.
They were like, that other nurse said it was gross, that I was ruptured. And I was like,
Aw.
oh, no, no, no. That's a medical term that we use. It means like, you're for
Yeah.
sure your water broke. We can see it. We might do
Yeah.
like a little test on it. But the ones that are really tricky are those slow leaks. And I just tell people,
Mm.
come in for any concern that you have, because we
Mhm.
do have more um efficient, like pretty accurate test that we can do. Even if you're not sure if it's urine or if it broke,
Yeah.
we'll test that fluid, and it can actually accurately tell us if your water broke or not.
Okay, cool. Um, awesome. Another question from pregnant parents that's frequently asked is, what is labor like?
Mm,
I
well,
feel like it's so different.
yeah, that I actually have like another good story just from the other day with that. My patient, it was her first baby, and she had a birth plan that she put a lot of work into, and we
Mhm.
really, really tried to go, as safely as we could, respect her wishes, but the baby had a different idea of how he wanted to be
Mm.
be born, and so whenever whenever I got there, she was 8 to 9 centimeters, and even though I've done this for so many years, my brain, my experienced brain said, "Oh, we're gonna have a baby soon. Let me prepare for this." And 7 hours later, we ended up in a C-section. So
Mm.
afterwards, when she was kind of talking through everything with me, she said, "I made this list and nothing came true on it." And
Mm.
I was like, "I know, and I'm so like, we really, really tried." And she said, "I wish I would have just known what was gonna happen." And I looked at
Yeah.
her and I honestly said, "Even I didn't know." I'm like, "Only God or the universe or whoever you believe in, it knows." And I'm like, "I've done this for my whole adult life, and I really thought you were gonna have a vaginal delivery when I walked in here this morning." So the truth is, we nobody really knows. We have certain puzzles to the piece that present itself throughout the day or a couple of days. That's another thing. First time labor.
Yeah.
We I think we're getting better at telling people this, but it's long. That's the number one thing, is like, be patient. Know that we will tell you if we have any concerns, but it's going to take a long time, especially if you're getting induced with your first
Mm.
and your cervix hasn't really dilated yet. And also if there's a medical reason, if we have to take the baby early at like 36 or 37 weeks for
Mhm.
preeclampsia or other really, really significant things that could be dangerous. Your body really isn't ready, but we need to get baby out. So that can be a long induction too. I'm talking sometimes 3, sometimes 4 days.
Oh my gosh.
Yeah, and I don't think people really understand that
Yeah.
sometimes. It's not full on, like, when in the cases when it's that long, it's not like full on Pitocin and you're really hurting. It's usually your a couple of the first days in the hospital, we're doing the prep work to get your
Mm.
cervix ready. So we're giving you either Cervidil or Cytotec, which are
Mhm.
cervical ripening agents, and sometimes you have to have a couple doses of those over a day or even 2 to get your cervix really, really ready so you have a fighting chance at having a vaginal delivery. And those are the times that it's a little more chill. I tell my patients, like, if you're getting Cytotec or Cervidil, get your laptops, watch movies, sleep as much as you can, because we're kind of
Yeah.
just doing the prep work before we really bring out the big dogs, whenever her cervix is ready.
Okay, so is it usually just kind of waiting around for dilation and
Mhm.
contractions happening, and then the baby comes?
Kind of. So, once again, never an easy answer.
Yeah.
Let's go with, like, a typical, sorry, I have to get my lip gloss off.
Oh, that's
Like,
okay.
hopefully that is out. A typical first-time induction,
Mhm.
because I feel like those are pretty common. It's your first baby, you come in, you're 39 weeks, you're just wanting to electively do this, and you're 1 centimeter. Like, you did a little bit of the prep work at home. It seems like, you were contracting the last couple of weeks,
Mhm.
having what we call Braxton Hicks, but it was enough to, like, really soften your cervix and kind of get it ready. Like, it feels soft to us, you've dilated to 1. We may be able to just start Pitocin.
Mhm.
Even in that, it could be like a day, but in that case, we're hooking you up to the IV, and we're just gonna slowly start turning it up. You're gonna be monitored the entire time because we need to keep track of your contractions and the baby's heart rate too, and we're also gonna be, like, watching your vital signs too. The one really cool thing is with, technological advancements that I've seen in the last few years, we have, like, a wireless monitoring system now depending on what hospital you're at. So that kind of gives you a little bit more movement for activity. Um, we'll slowly turn up the Pitocin throughout the day, and one thing that I firmly believe, is, like, a really common question or belief too,
Mhm.
is that people are like, "Oh, Pitocin, like, makes contractions so much worse." I really,
Mm.
really anecdotally don't believe that, because I've had patients on Pitocin for a couple of days um, before it actively or kicked their body into active labor, and they can just talk to me through them.
Yeah.
What I tell people, the one kind of there's a few universal, usually, rules in labor and delivery, everything else is a gray area.
Mhm.
The one universal rule is, like, once your water breaks, if it fully breaks, you have the big gush, that cushion's gone. So
Mm,
those contractions are going to be so much more intense than anything before.
yeah.
Before it breaks, some people can really tolerate and not even notice Pitocin contractions.
Hmm.
Some people, you'll contract with the Cytotec and Cervidil too. Some people can tolerate that and not even notice them. Everyone's so different, but typically people can handle that. Until their water breaks, and then the pain is a lot different. And people obviously can, like, all the time deliver without an epidural too when their water's broken. It just really is when they need to be more focused and in tune with the contractions.
Hmm.
Before that, it's like pretty casual most of the time as long as everything's going good. So we'll try to get you dilated to a certain amount, and then we have the option of breaking your water, but it doesn't really depend on what you're dilated to. It depends actually how engaged the baby's head is, because
Hmm.
we don't want to cause any kind of complication. So we need your baby to be pretty far down in your pelvis. It's up to your physician, because only like physicians or midwives can break water. RNs can't. We can do checks and other things.
Do
But
you
if
ever do spinning babies if they're
all the
not?
time, all the
Okay.
time. Yeah, yeah. I've incorporated that in peanut balls, like, with my daily
Yeah.
practice. Um, Before, if somebody doesn't have an epidural, I'm having them do a lot more stuff on their own of, like, standing, because I'm using
Hmm.
gravity, but
Yeah.
especially after epidural, we're spinning all day, I tell them. We're moving around every hour. But, if we're able to break your water, I don't know where I was going with that, sorry.
No, it's okay.
Um
Like
Break your
on the
water.
typical
Yeah,
induction.
if baby's low
Yeah.
enough, we can break your water. At that point, if you want an epidural, if you're one of those people that, like, walks in and they're like, "Michelle, I want an epidural, but I kind of want to experience a little bit of pain." I'm usually like, if we're gonna break your water later, if, like, the baby allows us to and whatever, you're gonna want an epidural shortly after that.
Mm.
We try to put, it looks like a crochet hook if anybody's seen it. And the physician will put a little kind of pinhole in it, because we don't want it all to gush out at once. So it'll be
Mhm.
like one of those slower leaks, high leaks that I told you about. But with every contraction, because we put that little pinhole in it, more fluid's gonna come out.
Hmm.
And the more fluid that comes out each time, that
It'll be
cushion's
more
shrinking and
painful.
shrinking. So those contractions go from
Yeah.
being like this to the more fluid comes
Yeah.
out. So I tell people, like, usually shortly after that, after we've had a few good gushes, you're gonna maybe be wanting it, or before. I tell some people too, if you don't
Mhm.
want to really experience that at all. Um, Once that happens, if we're able to break water, it usually does make things go a little bit faster. Once you hit about 6 or 7 centimeters, you're in active labor. And then from there, things really, really take off. That's the part where I'm in your room a lot more often too.
Mhm.
Pretty much after your water's broke, that's when I'm in there, like, every 15, 20 minutes, because something inevitably happens, we're moving, and baby's kind of getting lower on the monitor. And then however many hours later, it just depends on your body and if the baby's cooperating. But once you get to 10 centimeters and also the baby's low enough, because sometimes you can be 10 centimeters and we think the baby's really, really high up. So
Mhm.
your labor nurse will advocate for you, and your physician too, where we're like, let's do some spinning babies moves. Let's do some peanut
Yeah.
ball moves to get the baby to passively move down so that you
Mm.
have less pushing. Because the other thing that shocks people every single time that I tell them is the average first time mom with an epidural pushes, it's like 2 to 3 hours. And that's the
Oh.
average, meaning I've had people push a lot longer. And every once in a while, I have somebody not push that long with their first baby. And I always call them, if I have that good relationship with them, I'm like, I mean this in the nicest way. You're a freak of nature that you only pushed for 10 minutes with your first baby, because it's
Yeah.
really, really rare. My longest one that I was helping with, this wasn't my patient, but, like, it was a very, which is why I'm telling the story, very rare and specific set of circumstances. She pushed for 12 hours
Oh,
because
wow.
she did not want a C-section, and she talked it over with her physician, and, like, the baby stayed well that whole
Mm.
time, that wasn't giving us any signs of distress, and the mom wanted to keep going too. I would not recommend that for anyone.
Did she have an epidural?
Yes.
Oh, okay.
And, I honestly don't remember the outcome. No, I do, I do. I think she ended up delivering vaginally, but she had a very bad tear.
Mm.
I don't know how she felt about that afterwards. She had, like, a 4th-degree tear, which is a
Mm.
pretty significant, rare
Yeah.
complication that I wouldn't wish on anybody, but, your obstetrician can definitely, it ends up being kind of a surgical repair, and it's not fun. Um, but that's like another point that I make with people sometimes too, when things aren't going as planned, like
Mhm.
we're not, the baby's not moving down, or we're not getting to 10 centimeters and we've tried for days. I tell them that like our bodies are smart, and babies are smart. This is a little bit of that like superstitious part I was telling you about in healthcare. And I'm like, but the baby's giving us all of these signs, and your body is too, that something's not adding up. And we've
Mm.
tried, and we've exhausted all options. So sometimes if we're getting these signs, maybe we shouldn't push it too
Right.
far. And usually for failure to progress, which is a reason for a C-section, or failure to dilate, I don't know statistically, but like anecdotally, I feel like most of the time we'll deliver the baby in the C-section, and the doctor and I will tell mom, oh, that's why their head is like
Mm.
really crooked. We call it asynclitic, so they weren't coming down the right way at all, and we could
Yeah.
sometimes the baby's really really big.
Mm.
Usually, like, that's something we can kind of find out right away. So it's we never know. That's the answer.
Yeah.
But we
Okay,
love
so
questions too, and we love, which is why I can talk like this.
yeah.
We love explaining it to parents if staffing allows us, the different things that could happen, and what it would look like, and come up with a game plan for the day.
Right. Yeah, one of our another question, it's not on my question list, but is around tearing actually. Like if you are currently pregnant, how do you prevent tearing? So one way I guess would be not to keep pushing if your body is
Mhm.
showing that you shouldn't be.
Um, this is all like I've heard so many different things from so many different people.
Mhm.
One thing that I see commonly now is like warm compresses.
Mhm.
Some doctors will do whenever we're pushing. I've tried to incorporate that in,
Cool.
like gently, applying pressure to that. In my experience, I think that, and I tell my patients this too, that almost every first time mom tears. Your
Mm.
second or third, you may not, because that tissue is more elastic. It's just like your cervix too.
Yeah.
It's more elastic. It's been through stuff. Um, but it's typically just like a first degree tear. So it's just a lot smaller than you would think. A couple of stitches usually is like
Hmm.
the norm. Even with like smaller babies, most people will have just those couple of tears. But I wish I could like show a diagram. It's really, really not that bad. And we do dissolvable sutures now. So it's like a little bit irritating
Hmm.
for the first however long. But most people can't even really, they get used to
Yeah.
them after a while. More people complain about hemorrhoids, honestly,
Mm.
than, and like that kind of feeling they have after pushing, than
Yeah.
their tear if they have a first degree.
Okay, awesome. Yeah, you chatted about the difference between first and second time mom, so
Mhm.
or births in general. So, do first time parents typically deliver slightly earlier, and is it slightly harder when it's their first baby versus their second baby? What are your general takes on that?
I kind of feel like most people will go over with their first, unless there's, something else going on. But I also think that the body, once again, is really, really smart. So if it's listening and cooperating like it's supposed to, I feel like some of the people that may go into labor a little bit early are smaller, their baby's bigger, something happens. Once again, we really don't know. We don't know what is going to for sure make somebody go into labor, or
Yeah.
why their water breaks really early if we don't want it to break. But typically, I feel like the people that come into natural labor with their first a little bit earlier, they're like smaller, and their body's like, hey, well, it's, putting all the weight on their cervix. A lot of people now in America, in the hospital that I worked with, that I work in, get induced. It's still pretty common, so I don't have a lot to go off of
Mm.
that for,
Okay.
because it's just so many people do inductions now, which there's no wrong way, one way
Yeah.
or another. I don't think it's something, a really personal decision that you need to talk through with your provider and your support person,
Mhm.
and it's not something that anyone else can tell you what the right answer is.
Yeah. Okay, that makes sense.